How do you do? It's Bruce Gewirtz here at Cedars Sinai. It's truly my pleasure today to welcome my friend and colleague Irene Kim. Irene is the co-director of our Transplantation group, which spans transplantations in all solid organs. And Irene, it's great to have you here.
Thanks so much, Bruce, for having me. I'm so honored to be part of this.
So tell us a little bit about yourself. Where were you born and where'd you go to high school and alike?
Okay, I was born in Madison, Wisconsin. My parents did their PhDs. They are immigrants from Korea. And then a year after I was born, we moved to Bowling Green, Ohio, home of the National Tractor Pull, which is a very small rural town, but it happens to have a university there where my parents both got jobs. I was the only Asian in my whole school. I think all the minorities within the town comprised 1% of the population, Black, Hispanic, Asians, everyone. And that's where my childhood was. And after that, I moved to the East Coast, which seemed super cosmopolitan. I went to MIT and did 4 years there before deciding on a career in medicine.
When you went to MIT, had you thought about being pre-med, or were you pre-engineering, or how did you pick that?
So I think that growing up, I had always had this romanticized notion of medicine. I think I really wanted to find a job where I helped people. And so that desire came early. And I knew I wanted to do something either in science or in medicine at MIT. And pretty early on, I declared that I wanted to be pre-med.
Great. And medical school?
Medical school was at UCSF. I traveled from coast to coast from Boston to San Francisco, and that was an amazing experience. UCSF was really diverse group of students, and sometime during my medical school training, I decided that I hadn't had a lot of life experience. I had plugged along throughout MIT, my undergrad and medical school, and I lived with these two amazing roommates, both of whom had taken a lot of time to do other things. They had lived in Africa and Ecuador and had done all these interesting things with their lives. So I decided to take a gap year, and I lived in France between my third and my fourth years of medical school. And that was one of the most formative experiences of my life, living there.
Did you do medical things when you were in France?
I did. I was on paper working in a laboratory, but I think really the experience was about taking me out of my comfort zone and doing something completely different and living on someone else's turf, other people's rules, and having that life experience. And I think that was really good for my growth just as a human being. So I credit that experience to also becoming a physician and having a different experience that I wouldn't have ordinarily had in medical school.
I know my friend and ex-medical student, actually, Nancy Asher, was chief of surgery at UCSF. Was she a role model for you going into transplant?
She was actually one of my surgery mentors at UCSF. And I remember attending a conference, or it was like an informal meeting, a gathering about women in surgery. And she kind of made the statement like, when are we going to stop talking about women in surgery? We should just talk about people in surgery. And that definitely stuck with me. And I just realized that she didn't see this as a gendered thing. It shouldn't be such an issue being a woman in surgery, choosing surgery. Do it if you want to do it. Do it if it makes you excited. And so I definitely saw her, and she still is a role model.
Great. So you moved back to the East Coast for residency.
Yes, I did. So I matched at Tufts Medical Center. At that time, it was called New England Medical Center. And that was also a fantastic experience. I specifically wanted to be in Boston for my training because I had such good fond memories of my undergrad days there. I'll be honest, it wasn't the top of my list for residency programs. I had always wanted to be at like a Harvard program or, one of these big flashy name programs. But as it ended up happening, I matched at Tufts, and it ended up being one of the best things that have happened to me in my life. And the reason for that is because that's where I found transplant.
Tell us about that.
So I went into residency thinking I wanted to be a pediatric surgeon. I had done some research and some work with Mike Harrison at UCSF. He's kind of the father of fetal surgery, and I wanted to do pediatric surgery when I got to Tufts. But then I met the 3 transplant surgeons at Tufts who were just amazing human beings, amazing people. And they were also technically one of the most gifted groups of surgeons within the hospital. So I started doing more cases, asking to scrub more cases with them. And throughout my early years of residency, I just got inspired. And I think that when you are an impressionable surgery resident looking for a field, having really strong role models can have a huge influence on what you decide to do in your career. And because of these 3 surgeons, who are Rick Rohr, Richard Freeman, and Jeff Cooper, they are the ones who truly inspired me to go into transplant.
So then you picked up some more frequent flyer miles and went back to the West Coast for your...
I feel like I'm ping-ponging between the 2 coasts, yes.
Your Transplant Fellowship at Stanford.
Yes. So then after I decided to go into transplantation, there's also a match process for Transplant Fellowship. And I matched at Stanford University and did my training under the great Carlos Esquivel, who is an expert in pediatric transplantation. And I learned kidney transplant and liver transplantation during that fellowship.
Great. And we were really fortunate to have you come here to Cedars Sinai, where you've been a tremendous force for good in the transplant area overall, but specifically in kidney transplants. What is it about kidney transplants that has so focused you?
Well, I think all of transplantation is beautiful. By the way, I did a liver transplant last night. We tend to do our cases in the middle of the night, and I do about half and half liver and kidney transplantation. But overall, transplant across the board, I love the stories that are involved in transplantation, the gift of life from the donors who are so selflessly, in times of grief, in deceased donation, thinking of others and making other lives better with that gift. So there's that emotional component to the field that I really identify with. And then there's the technical aspect of transplantation that I love. Transplant is really complex surgery. It requires vascular surgery techniques and also a know-how of pretty complicated medicine, because all these patients have to undergo immunosuppression in order to accept an organ. So I really like that combination of medicine, emotion, in the field.
Now, we're very proud of the fact that not only you are a superb clinical surgeon, you are a great administrative leader, an inspirational leader, but you also have a major commitment to translational research. Can you tell us about your research?
Early on at Cedars, I knew I wanted to embark in a research career, and I was fortunate enough to align my research with Stan Jordan. He is our director of nephrology within our transplant division. And Stan's work is really directed towards antibody-mediated rejection, which is there are 2 arms in your immune system, if you will. One of them is cellular rejection, when the cells in your body reject something that is foreign. And then also the antibody arm. So anyway, he focuses on the latter aspect of immunosuppression. And so I had some extra time on my hands when I first came to Cedars, and clinically I wasn't so busy. So I started working in the laboratory doing research on antibody rejection in mice, specifically related to a really small cytokine called IL-6. And anyway, the science is fascinating, but the important part about it is that from that research, we discovered a new pathway, a new drug pathway to treat patients who have antibody-mediated rejection and may lose their transplant grafts from that. So it was really cool to see something that was born out of a laboratory experiment that we did on mice, and then be able to apply that same kind of condition to our real patients. And from that came just a wealth of information and therapeutic pathways to treat patients.
Yeah, it's the classic bench to bedside transition that has been so evident in transplantation over the last 30 years. Now, I'm aware of the fact that you and Stan and the transplant group here have a international reputation for taking patients who are sensitized and or taking patients who get a transplant from someone where there'd be no reasonable synchronization of their immune system. That is, I have a friend that you transplanted who got a transplant from his wife. And how does that work first? And then maybe we could talk a little bit about the implications of that for the transplantation need for organs problem.
So transplantation would only be possible with immunosuppression, and these are a whole host of drugs that you have to go on when you receive a life-saving organ transplant. What allows that gift to happen, your friend accepting a kidney from his wife, are these medications that we have available. There are some patients who have developed antibodies that make it prohibitive. Not all patients. Some patients don't have these antibodies, but some patients throughout your lifetime develop antibodies that make it sometimes impossible to accept an organ from another patient. And those patients are really the patients we focus on in our research here at Cedars Sinai in the transplant nephrology group. The pathway for those patients that make it prohibitive to receive a transplant is something called antibody-mediated rejection. And what we do is we look at different pathways to help suppress, remove antibodies that make a transplant compatibility not possible. The research that we do here, we've developed several protocols that are unique to Cedars Sinai, and those are called our desensitization protocols. About 30% of patients on our kidney transplant list at Cedars are referred to us because they have high antibody load and couldn't otherwise have an organ transplant at any other transplant center.
Now, it's my understanding that the biggest challenge for transplantation in general is the availability of organs. And as compared to other countries, how good, I guess, is the supply of organs in the United States relative to the population?
So, in general, organ transplantation is culturally influenced. There are some countries that were late to identify deceased organ donation. And in our country, I would say that we are fairly generous as a culture and society in accepting and identifying, acknowledging organ transplant. We have an opt-in system, so if you are an organ donor on your driver's license, when you renew your license every so often and you decide to be an organ donor, that will be marked on your driver's license. And then there are other cultures that are actually an opt-out society. So, for example, in Spain, that's an opt-out system. It's assumed that everyone will be an organ donor. One of the unique features of the United States is that we have a very heterogeneous population versus other countries, for example, again, Spain, that have a more homogeneous population in their deceased donor organs. And so sometimes that heterogeneity makes it difficult to utilize organs. Right now in the United States, there's a greater push to try to use all deceased donor organs. And so there are some allocation changes that are happening in organ transplantation to incentivize surgeons, transplant providers to try to use all deceased donor organs.
Yeah, I guess the trade-off is that anytime you operate on someone, particularly a transplant, that they're going to have to be immunosuppressed, you take a risk with that patient. So if you as a surgeon feel the organ quality isn't so great, or the match is so disparate that the chance of long-term success wouldn't be so great, that you would be more concerned about moving forward with that transplantation than you would if it was well matched.
Yes, and we have those conversations daily with patients. One example is matching older quality kidneys, older donor kidneys with older patients. And the downside of accepting an older organ is that it won't last as long, usually. Research has shown that those organs do have a shorter lifespan. But the upside is that you may get off the transplant list faster if you accept one of these older organs. So we have these conversations about benefit and risk all the time with patients. And ultimately it comes down to, what would you do, doc, if it were you? And I think getting off of dialysis sooner and buying 5 years off of dialysis with an extended, more marginal organ is worth that trade-off.
So if you were to look down the road, as I know that you do, what are the most likely sort of big advances that you see in the next 20 years of your career? If you were to fantasize about what transplantation would look like in 20 years, what problems do you think you will solve in your field?
So the biggest problem is organ availability. And I hope that we see a day when we can construct these organs in regenerative medicine and make biomedically engineered organs. There's a lot of research behind that. Or even use organs from animals, something called xenotransplant. Now, the problem with xenotransplant is that there are even more immunologic barriers to accepting an animal graft taken from an animal. It's more foreign to a human patient than human to human. So I do think that the big game changers coming down the pike in transplantation will be manipulating the immunosuppression or manipulating the genes that are involved in these rejection responses.
What about if you were to, since the organs themselves, and this is obviously a generalization because every organ is different, but the organs themselves have the placement in the body, the blood vessels, and the structure to do their job. It's just that the metabolic cells within the organs stop functioning. Is there work being done in which the cells are effectively replaced by better cells?
Yes, there are some trials, clinical trials, using stem cell infusion. So especially with the liver and sometimes with pancreas. Those are the two main organ systems that I'm thinking of, that kind of technology, that attempt at restoring cell populations exists. But they've met kind of measured success, and oftentimes, despite infusion of these stem cells, so for example, pancreatic islets, those cells don't tend to last very long. So even if you infuse pancreatic islets into a patient, you do restore for some time insulin producing cells and make a diabetic patient non-diabetic. But typically the downside is it only lasts for several months, maybe several years. And then the patient has to go through that all over again. So I think that will also be a huge game changer in medicine if we can find a way to increase the longevity of those types of stem cell infusions.
Yeah, having been a surgical chairman for more than 30 years and having recruited a number of islet cell physicians, I've learned the famous statement that islet cell infusion is the future of transplantation and always will be.
Yes.
So, Irene, one
accurate.
of the other remarkable things about you is you live such a a full and balanced life. And I know you have 3 adorable kids who I've seen splashing, two adorable kids. One's not so adorable, but correcting it, the total is 2. And I've seen them splashing around in pools and thoroughly enjoying their mom and dad together. How do you pull it off? How do you sustain that kind of full life while you're sewing in livers and kidneys in the middle of the night?
I credit a lot of it to my parents who live with my husband and I and help us a lot with our kids. My parents are retired professors, and it's a huge ask. It's amazing, and I thank them every day for the sacrifices that they've made. They should be traveling the world and enjoying retirement, and here they are helping us with our 2 young children. But actually, during this era of coronavirus, it's helped them stay active. They wouldn't be traveling anyways. So I think we just see it as having one big happy family. And I credit my husband and I credit my parents a lot. I mean, it's hard to think about living with your in-laws all the time. That would be really hard. And think about living with your son-in-law all the time. So it kind of goes both ways. But I think that it's also testament to my family and how gracious they are with one another and patient they are with one another. I'm very lucky.
Well, we're lucky to have you, and we look forward to continued extraordinary success in your career here at Cedars Sinai.
Oh, thank you so much. I appreciate it.